Good morning, colleagues. I'm sure you're wondering why I'm reaching out to you this morning, and there is a reason. We are falling out big time on the sepsis measures, on that core measure. And that's just not normal for us because we're number one on all the other core measures. So Chris Burke and Doug Archer asked me to look at all the cases of sepsis that come in through the ER and see if I can try and find out what the common thread may be that's causing us to fall out on this measure. And I've been doing that for the last 2 months, and I think I've got some understanding of what might be the case. So here's the crux of what I think's going on right now. CMS defines sepsis as a bacterial infection that invades the bloodstream, causing organ dysfunction, possible hypotension, and death. It is not a fungal infection. It is not a viral infection. It's a bacterial infection. It is not an inflammatory process. It is not a volume depletion process. So therefore, it's not acute cholecystitis, which is gallstones, inflamed wall, which may have nothing to do with bacteria unless there's an empyema. It's not necessarily appendicitis, which can be appendolith, inflammatory process, but in the absence of an abscess, not necessarily sepsis. Same thing with pneumonia. Pneumonia doesn't necessarily equate to pneumococcal sepsis. Cellulitis of the skin, not a bacterial invasion of the vascular endothelium necessarily. And it's not necessarily volume depletion. We get lots of patients that come into the ER with C. diff, massive volume depletion. Their BUN's up, creatinine's up, their heart rate's up, their temperature's up. But that's a local colonic inflammatory process. It's not bacterial invasion of C. diff. So you can see that the differentiation of sepsis from volume depletion and an inflammatory process is a sophisticated analytic process that usually requires a med school degree. And the coders, as you probably realize, are basically high school grads. So they have been told if any doctor calls a case that calls a patient septic, the coders are required to treat that patient as sepsis, even if it's not. Now, the coders look at the ER record, the hospitalist note, cardiologist note, general surgeon's note, EICU note, anesthesia record. They look at the whole hospital document. If one person calls the patient septic, it's sepsis. And if you call it sepsis, even if it isn't, we are required to pay. You own it and you got to pay for it. And here's what I mean by that. You call it sepsis, within 3 hours, you need a blood culture, you need a lactate, you need antibiotics on board. If the blood pressure's low or the lactate's greater than 4, and by blood pressure being low, I mean a systolic less than 90, lactate greater than 4, you need to give 30 cc's per kilogram of fluids. In 6 hours, you need a repeat lactate and a central line if that blood pressure is not improved. That's what you got to pay if you call it sepsis. So here, my colleagues, is where we're falling out. I believe we're labeling too many patients as septic. And if we do, and what I see in the charting is when we do label patients septic, we're not ordering the 6-hour lactate. And I think we need to be more aggressive with fluid administration. I think if we can start looking into I think if we can be a little bit more careful about calling a patient septic that's not septic, I think we're going to do a lot better on this measure. So thanks for your time. Appreciate it. Adios. Bye-bye.